Good morning and welcome everyone. Today is October 21st, 2021, and I'm pleased to call today's ACIP meeting to order. I just want to check with Dr. Melinda Wharton to make sure there are no quick announcements before taking roll call. She reassures me there are no quick announcements. Okay. I am happy to take roll call with our ACIP members. And again, as a reminder to our ACIP members, be prepared to just state your name, affiliation, and whether you have any conflicts of interest. Today I'm going to start with Dr. Kevin Alt.
My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas. I have no conflicts.
Thank you. Ms. Bata.
Good morning, Lynn Bata. I am the immunization program clinical consultant for the Minnesota Department of Health, and I have no conflicts.
Thank you, Ms. Bata. Dr. Bell.
I am Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Thank you. Dr. Brooks. Dr. Brooks. Welcome back to Dr. Brooks. Dr. Chen.
Wilbur Chen, Professor of Medicine, Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you, Dr. Chen. Dr. Sineas.
Dr. Sybil Sineas. I am an internist and pediatrician, associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly.
Matt Daly. I'm a pediatrician and senior investigator at Kaiser Permanente, Colorado, and also an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts. Thank you.
Thank you. Dr. Cotton.
Camille Cotton. I'm the clinical director of transplant and immunocompromised host infectious disease at Massachusetts General Hospital and associate professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Lear.
I'm Dr. Jamie Lair. I'm a private practice family physician in Ithaca, New York, and I have no conflicts.
Thank you, Dr. Lair. Dr. Long.
Good morning. This is Sarah Long. I'm a pediatric infectious disease physician and professor of pediatrics at Drexel University College of Medicine in Philadelphia, and I have no conflict.
Thank you, Dr. Long. Ms. McNally.
Good morning. Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Good morning, and thank you. Dr. Paling.
Good morning. It's Kathy Paling. I am professor of pediatrics and epidemiology at Wake Forest School of Medicine, Atrium Health, Baptist Health, Wake Forest Baptist, and I have no conflicts. Thank you.
Thank you. Dr. Sanchez.
Morning, Pablo Sanchez. I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital and a professor of pediatrics at the Ohio State University College of Medicine, and I have no conflict. Thank you.
Thank you. Dr. Talbot.
Good morning. I'm Kip Talbot. I'm associate professor of medicine and health policy and adult infectious diseases at Vanderbilt University Medical Center, and I have no conflicts.
Thank you. And I'm Grace Lee. I'm Associate Chief Medical Officer at Stanford Children's Health and Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts. We anticipate Dr. Brooks will be joining slightly later. And I am going to actually turn it over first to Dr. Melinda Wharton, who will make a few comments and introduce the next speaker.
Good morning. I'd like to invite Dr. Fink, if he would like to make a brief statement about FDA regulatory actions yesterday.
Hi, good morning. Thank you for the opportunity. At yesterday's meeting, I did preview some announcements from FDA, which occurred late in the afternoon. FDA has now authorized the Moderna COVID-19 vaccine for use as a single booster dose at least 6 months following completion of a primary series of the Moderna COVID-19 vaccine. in individuals ages 65 and older, as well as individuals 18 through 64 years of age who are either at increased risk of severe COVID-19 following primary vaccination or who have frequent institutional or occupational exposure to the SARS-CoV-2 virus. Additionally, FDA late yesterday afternoon authorized the Janssen COVID-19 vaccine for use as a single booster dose at least 2 months after the single dose primary vaccination in individuals 18 years of age and older. Finally, FDA authorized use of all 3 of the available COVID-19 vaccines for use as heterologous booster doses following completion of a primary vaccination with any of the 3 authorized COVID-19 vaccines. Because need for a booster dose is determined by the immunity elicited by the primary vaccination or primary vaccination series, the populations eligible for heterologous booster dose and the appropriate interval between completion of the primary vaccination or primary vaccination series and the booster dose is the same as those populations that are eligible for the a booster dose of the primary vaccine, as well as the dosing interval is also the same as the dosing interval authorized for the vaccine used for the primary vaccination. I'm happy to answer any questions about these authorizations as today's meeting progresses. All of these authorizations followed discussion and recommendations from our Vaccines and Related Biological Products Advisory Committee last week. Thank you very much.
Thank you, Dr. Fink. If there's no immediate questions, we'll proceed to some introductory comments from Dr. Rochelle Walensky, the CDC Director. Dr. Walensky, welcome to the meeting.
Good morning. Thank you. Good morning, everyone. I'm delighted to be here today to just say a few words, especially during yet another busy 2 days of meetings and discussion. Let me start by simply saying thank you. For over a year, this committee has met to discuss COVID-19 vaccines, analyzing the studies and ever-evolving data, establishing a framework for equitable delivery, diving into the safety data, and making recommendations that keep people safe and protected against disease. And despite the enormity of the task, you have not wavered in your commitment to the work in front of you, and I am so grateful to have you here to provide us all insight, guidance, and recommendations. As always, you again have a tremendous amount of work ahead of you today. Each presentation is evidence-packed, and I am appreciative for the heavy lift you are about to undertake. From a discussion on the benefits and safety of a booster dose of Moderna for those at greatest risk, to the best way to protect those who have received the Janssen vaccine, to a conversation about heterologous vaccine series and what we can extrapolate from the clinical trials and laboratory studies to real-world data. Your votes are important, and of equal importance is how you approach each of these data and frame your recommendations. When I spoke with you last month, I made 3 commitments to you: to never lose sight of your collective goal to protect as many people as possible from COVID-19, to stand with you as we move forward and face new decisions, new twists and turns in this pandemic, and to listen to you and learn not just from your votes, but from your discussion and deliberation. These past 20 months have taught us many things, but mostly to have humility. We are constantly learning about this virus, growing the evidence base, and accumulating more data. None of us individually can predict what may happen next, and none of us individually can know exactly what to do. But together, we can be prepared and make the best recommendations to protect the greatest number of people. Please know that I am here listening and eager to learn from your perspective. Over the coming days, we will release clinical considerations and public health guidance that will turn these decisions into practice. CDC's recommendations will not just address who should receive a booster dose, but also include what vaccine they should receive, how, and when. It is your conversations that we will explore the nuances of this guidance and then communicate it to the public. You have a busy day ahead of you, and I want to let you get to your discussion, but I want to take one last moment to share my deep thanks to the ACIP team here at CDC. They have spent countless hours preparing for these meetings, responding to data asks from the working groups and full committees, presenting the evidence, and establishing the framework for your recommendations. They are an incredible, dedicated, tireless, and committed team. Thank you for giving me the chance to speak with you and for the hard work you are about to do. Know that I am here listening and looking forward to hearing what you have to say. Thank you.
Thanks so much, Dr. Walensky. At this point, I'll turn the meeting back over to Dr. Lee.
Thank you very much, and thank you, Dr. Walensky. I wanted to just comment that your comments were really important to us. As you said, leading with humility, honesty, and transparency is all that we can do as a committee, and we appreciate your deep engagement in the work of the ACIP. We will now move forward to the first session of the morning. Our favorite topic, of course, is COVID-19 vaccines. During today's meeting, I will invite individuals to contribute to the discussion. Please raise your hands electronically, and I will call on ACIP members first, followed by our ex officio members and liaisons. If you wish to respond to a particular comment or question, please try and indicate this electronically. Dr. Daly, the chair of the COVID-19 vaccines work group, will provide an introduction and overview of this morning's session. So, Dr. Daly, over to you.
Thank you very much, and good morning to everyone. I'll present on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. This is a graph that we've shown before, but there's a couple points I want to highlight. Daily cases is on the y-axis and time on the x-axis. And over the course of the pandemic, there have been almost 45 million total cases in the United States. And even though the epidemiologic curve looks a little bit better than it did 1 month ago, there are still, on average, about 75,000 new cases per day in the United States. Next slide, please. And then this slide shows the daily trends in the number of COVID-19 deaths in the United States. And currently, there are approximately 1,000 deaths in the U.S. every day. And this is an important place to make the point that for most individuals, in most circumstances, death from COVID-19 is vaccine preventable. Next slide, please. So here are the activities that the COVID-19 Vaccines Work Group has been engaged in the last 6 weeks. We've considered booster doses for COVID-19 vaccines, and this has included review of real-world vaccine effectiveness studies, both from the U.S. and from abroad. In addition, the work group has reviewed randomized controlled trial safety and immunogenicity data regarding booster doses. We've also had the opportunity to review National Institutes of Health heterologous or mix and match study results, and we're going to hear those again today. And then we have reviewed the grade or quality of the evidence regarding boosters, and then also discussed at length the evidence to recommendations or ETR framework regarding implementation, values, acceptability, resource use, and equity in the consideration of the use of booster doses in the United States. And then finally, we've also pivoted to prepare for our critical decisions coming up around the use of COVID-19 vaccines in a younger pediatric age group, 5 to 11. This has included a review of SARS-CoV-2 seropositivity in children. And then also we've had a much closer look at the current pediatric COVID-19 infection epidemiology. Next slide, please. So as has been reviewed by Dr. Fink just a few minutes ago, the FDA expanded Moderna COVID-19 vaccine EUA to include a single booster dose to be administered at least 6 months after completion of the primary series in the following groups: individuals 65 years of age and older, individuals 18 through 64 years of age at high risk of severe COVID, and individuals 18 through 64 years of age with frequent institutional or occupational exposure to SARS-CoV-2. In addition, as Dr. Fink has mentioned, the FDA also expanded the use of Janssen in terms of the use of Janssen COVID-19 vaccine emergency use authorization to also include a single booster dose. In this case, to be administered at least 2 months after completion of the primary series for individuals 18 years of age and older. And the FDA also amended the emergency use authorizations to allow for each available vaccine to be given as a heterologous or mix and match booster dose, meaning that someone who completed the primary series can receive a different vaccine product as their booster following completion of the primary series. Next slide, please. So here's the agenda for today. First, we'll hear from Dr. Miller from Moderna, who will present data on Moderna booster doses. After that, we'll hear from Janssen. We'll hear from Dr. Heaton and Dr. Dwogi from Janssen regarding booster dose data. This will be followed by a presentation from Dr. Atmar from Baylor College of Medicine, who will present data on the NIH mix and match booster dose study. That'll be followed by a break and then a public comment period. Following public comment, we'll hear from Dr. House at the CDC about vaccine safety, in particular from data from VSafe and data from VAERS regarding what's known about the safety of third dose in these systems. In addition, data about administration of other vaccines at the same time or simultaneous vaccination. We'll hear some additional vaccine safety updates from Dr. Shimabukuro at the CDC. Following Dr. Shimabukuro's presentation, we'll hear an update from Dr. Su at the CDC regarding the myocarditis data from VAERS. Following Dr. Su's presentation, we'll hear from Dr. Klein from Kaiser Permanente, Northern Colorado, who will present data on what's known about myocarditis from the Vaccine Safety Data Link, or VSD project. Following Dr. Klein, we'll hear from Dr. Talbot, who's an ACIP member, and she is the VAST chair. The VAST group is the Vaccine Safety Technical Subgroup of the COVID-19 Vaccines Work Group, and she'll present the VAST summary of their assessment of what's known about COVID-19 vaccine safety. Following Dr. Talbot's presentation, we'll have a break. Next slide, please. And then we'll hear from Dr. Jones, who's at the CDC and will present data on COVID-19 vaccine effectiveness of the primary series. Following Dr. Jones's presentation, we'll hear from Dr. Dooling at the CDC, who will present the evidence to recommendations framework for booster dose considerations. We'll then hear from Dr. Reddy at the CDC, who will present the clinical considerations around the use of booster doses. And then we'll hear again from Dr. Dooling at the CDC, who will review the policy questions which will be brought to the ACIP for a vote, and then there'll be a discussion. Following that discussion, we will have a vote regarding the use of Moderna COVID-19 vaccine booster doses, and then we'll have a second vote regarding Janssen COVID-19 vaccine booster doses. Next slide, please. So I'd like to thank the tremendous work of the COVID-19 vaccine work group members. This includes ACIP members. It also includes ex officio and government members listed below, as well as liaisons and consultants, and then the outstanding leadership of Dr. Sarah Oliver and Dr. Kathleen Dooling. Next slide, please. As well as a host of CDC participants who, as Dr. Walensky said, have contributed countless hours to this work, and we thank them greatly as well. Next slide, please. So, Dr. Lee, I'll pass it back to you.
Thank you, Dr. Daly. And I would like to take a moment to recognize Dr. Oliver Brooks, who is on the line. Dr. Brooks, if you could state your name, institution, and if you have any conflicts of interest.
Yes, I've been on the audio the whole time, but Dr. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation, no conflicts. Thank you, Dr. Lee.
Thank you, Dr. Brooks. And now we will move on to Dr. Jacqueline Miller from Moderna to discuss the booster dose data from Moderna. Dr. Miller?
I am Jacqueline Miller, and I am the therapeutic area head for infectious diseases at Moderna. I really want to thank the ACIP half of the company for the opportunity to present our booster dose data, and also add our thanks for your relentless pursuit of the appropriate public health implementation of these vaccination programs. In my talk today, I'm going to be reviewing with you the emergency use authorization for a 50 microgram booster dose that Moderna has submitted to the FDA.
Dr. Miller, I'm wondering if you might be able to step closer to the microphone. It's a little muffled, your voice.
Apologies for that. We'll try to make that better. So is this a little bit better? Are you able to hear me now?
We can hear you. It's just a little bit muffled. We just want to make sure we can hear the presentation clearly. Why don't you go ahead and we'll monitor in the room to make sure that everyone can hear you. Thank you.
Okay, thank you. I'll try to speak up and hopefully that will help. So what I'm hoping to do today is review for you the updated phase 3 efficacy data from our Cova study and how that informs our decision to submit this booster dose application. I'll then talk about the safety of the booster dose as well as the immunogenicity. Next slide, please. So as Dr. Fink reviewed, the emergency use authorization for Moderna COVID-19 vaccine is for a 50 microgram booster. And it's particularly authorized for patients at increased risk of severe complications, including those over 65, those over 18 but younger than 65 at high risk for severe COVID-19, and those with frequent institutional or occupational exposure. And then additionally, our fact sheet will also reference the ability to use the Moderna booster dose as a booster for other vaccine primary series. Next slide, please. So first, I want to review with you the booster dose and then also review how that is different from the 100 microgram 3-dose primary series that's been authorized for certain populations. Back in August, it was noted that patients with solid organ transplant or who are otherwise immunocompromised did not always develop neutralizing antibodies to any of the authorized vaccines. And therefore, Moderna submitted and had authorized a 100 microgram dose that's to be given at least 1 month after the second dose. This is really a 3-dose primary series for patients with compromised immune systems and is not the indication that we're discussing today. Today, we will discuss for other populations who received a 2-dose 100 microgram primary series, the administration of a 3rd dose at least 6 months after completion of the 2-dose series with a 50 microgram booster. Next slide, please. So I did want to mention before going into the rest of the presentation that we do have now approximately 1.6 million Americans who have received a 3rd dose of 100 micrograms in the immunocompromised population. And those are the safety data that will inform part of the discussion later this afternoon. Next slide, please. So now let's review an update from our phase 3 efficacy trial and the incidence of COVID-19 disease that we are seeing as subjects progress through their follow-up period. Next slide. So we completed a follow-up of the blinded efficacy analysis through March of 2021. Why through March? Because after the EUA authorizations of Moderna's vaccine, the subjects in the placebo group, which should be recalled, were all at increased risk for COVID-19, were offered crossover vaccination. And in order to continue to follow and learn in this study, we crossed over those subjects and continued to compare incidence rates. So there was a final blinded efficacy analysis, vaccine group versus placebo group, through March of 2021. And at that time, through 5.3 months of median follow-up, efficacy remained 93.2%. Next slide. And then the efficacy against severe disease throughout the same period remained 98.2%. So very similar to the results we discussed last December. Importantly, during the time of this follow-up, when cases are reported in the trial, we sequenced them. And we noted that the original strain with the D614G mutation and the alpha variant were by far the most commonly circulating strains during this period of follow-up. Next slide, please. So now let's discuss what happened as we conducted an exploratory analysis and also during the same period began to see other strains emerge in the U.S. Next slide. So as I mentioned, as variants began to emerge in other parts of the world, the Beta variant in Africa and the Gamma variant in South America, we've been testing throughout our program serum from recipients of 1273 to assess how well we're able to neutralize antibodies against those variants. This slide shows the results of an exploratory analysis that was conducted early in the winter, so around February, March of this year, where we looked at whether a 50 microgram booster could increase the breadth of coverage in terms of neutralizing antibody responses. And this is what we learned. In the left-hand panel of the slide, you see a bar graph in dark blue against the original Wuhan strain, and then in light blue against the Beta, and in red, the Gamma variant. And this is 1 month after dose 2. So what you can see is that all subjects develop neutralizing antibody titers to the original strain. And most subjects develop neutralizing antibody titers against the 2 variants that were tested. We know this based on the titers for the individual subjects in the open circles being above the dotted line. The dotted line represents the limit of quantitation of the assay. Now in the middle panel, you see what happens to those subjects 6 to 8 months after they've completed dose 2. In dark blue, you see that all but 1 subject retained neutralizing antibody titers to that original Wuhan strain. But it's a different story when we consider the Beta, Gamma, and now in orange, the Delta variant. And approximately half of the subjects in each case have lost the ability to neutralize the variant by 6 to 8 months later, which is probably a combined reflection of lower neutralizing antibody titers to begin with, and the known waning of antibody persistence that happens with all vaccines over time. Now in those subjects, we give a 50 microgram booster in the right-hand panel. And so for all 4 of the strains, we are now able to have everyone be above that limit of quantitation of the assay, with fold rises between 23 and 44-fold in an exploratory research-grade assay. Next slide, please. Okay, so now let's talk about the incidence rates of COVID-19 disease in the July and August timeframe when Delta variant began to become the most commonly reported variant. Next slide. So I mentioned to you earlier that we had an original group of subjects, mRNA 1273 in blue, in our phase 3 study. And those individuals were vaccinated between July and October of 2020. Then there was an originally randomized placebo group in gray. And those subjects received the placebo between July and October, but ultimately were crossed over to receive mRNA 1273 in January to March of 2021. And so while we could no longer conduct a true efficacy trial with a placebo group, we do have two groups, one which was vaccinated earlier, so about a year ago at this point in time, and one that was vaccinated later, about 6 to 8 months ago at this point in time, to compare relative incidence rates. And meanwhile, we're following very closely the reported cases of COVID-19, which are still being assessed and confirmed by the adjudication committee as the subjects progress through efficacy follow-up. And as you see in the bottom bar graph, the most cases we had reported up until July of this year was 23 in January of 2021. In July, we observed 81 cases, and in August, 169 cases, which is clearly a difference between what we had been observing previously. And that really prompted us to take additional action and do additional analysis. Next slide, please. So now, you see a comparison of incidence rates in this bar graph, both overall on the left and then by age group, 18 to 64, and those greater than 65 years of age. In the group overall, we saw in the earlier vaccinated group an incidence rate of 77.1 per 1,000 person years, compared to 49 per 1,000 person years in the later vaccinated group, for a relative difference of 36.4% that was statistically significant in that the 95% confidence interval rules out the value 0. And the same is true in both of the age strata presented on the slide. In the oldest age group, for severe disease, the group difference is even larger, as is the lower limit of the 95% confidence interval. Next slide. So now we come to what are we going to do about the challenge of the increased frequency of reported cases. And back when we had followed up our phase 2 subjects, so this is now a much smaller sample size, but a group in January to March who had previously been vaccinated in the phase 2 study and were eligible for further evaluation of boosters. Next slide. And why did we choose a 50 microgram dose? Primarily because our goal is always to use the dose that can be most optimally effective for boosting. And really, the principle is to expose subjects to the dose that they need, but not expose to more than they need. We also know that lower booster doses than those used in primary series are used for other vaccinations. And a key example is Tdap. This is because these booster vaccines are able to reactivate immune memory. The immune system is starting from a different place at that booster than it was pre-primary series. And that's important because you are often able to get a better boost than you were initially, even with a lower dose. And then finally, lowering this dose actually increases our ability to supply mRNA 1273, not only in the US, but the rest of the world. Next slide. So now I'd like to talk about the study design of the booster phase of the phase 2 study. And this is an extension of the same phase 2 studies we discussed in December. The placebo group in the phase 2 study were also crossed over to receive mRNA 1273 primary vaccination, and they did not participate further in this study. There were 2 additional groups. One group was primed with 50 micrograms of 1273, and one group was primed with 100 micrograms of 1273. And I want to mention that the reason why the phase 2 study was chosen, even though it has a smaller sample size, was because the phase 3 study had only just finished their vaccination. So they really hadn't progressed long enough in the study to receive a booster dose. You see that the sample size for the immunogenicity set was 146 and 149 subjects respectively. That rises to 100 73 and 171 subjects for safety, resulting in a total of 344 subjects as the total safety database that received the 50 microgram dose. And we compared the immunogenicity of this booster dose to a subset in the Cova study. So 1,000 subjects provided the immunogenicity data that you'll see us compare. Next slide, please. So just to give you a sense of the demographic characteristics, in the right-handmost column, you see the 50 microgram dose pool, and then subsequently, because in other slides I will call out the 100 microgram primary series specifically, since that is the population that we will be boosting if we move forward, just to compare and show you that the demographics were the same. The mean age in this case was 52. There was a majority of female subjects, and most subjects were white. I want to also mention that we are increasing the sample size of the subjects we will boost, and this is ongoing in the phase 3 study, where we will evaluate in a larger and more diverse population safety and immunogenicity, as well as effectiveness of that booster dose. Next slide. So now let's review the safety data. Next slide. So similar to what was done in the phase 3 study, we collected solicited adverse reactions in a diary card for 7 days after the booster dose. We collected all unsolicited AEs for 28 days, and then we continued to collect SAEs, medically attended AEs, deaths, and AEs leading to discontinuation. Slide. So now we have the same local solicited symptoms that I reviewed with you in December: pain, erythema, swelling, and axillary swelling and tenderness. And in this case, you see the data from the 50 microgram booster, which is after the 100 microgram primary series, compared to the post-dose 2 results in the pivotal phase 3 study. I'm comparing to the pivotal phase 3 study because those are the data that are included in our fact sheet. And what you can see is that overall, the reported rates are approximately comparable in the booster dose as compared to dose 2 of the primary series. For all of the solicited adverse reactions, the only reaction that's reported most commonly after the booster dose than the second dose is axillary swelling and tenderness. Most events remain mild to moderate in severity, and their median duration is less than 3 days. Next slide. And now you see the solicited systemic symptoms. Here, overall, the reports tended to be lower than after the second dose of the primary series. Once again, most events are mild to moderate in severity, and the median duration is less than 2 days. Next slide. And then finally, a comparison of the unsolicited AEs, including medically attended AEs, SAEs, deaths, and those leading to discontinuation. And again, we see a rate that is approximately equal to what we observe in Cova for all of these events. Next slide. So now moving to immunogenicity data. Next slide. Our strategy in terms of demonstrating the effectiveness of the booster dose was to conduct immunobridging to the subset of the phase 3 study. And that really is because the phase 3 study was linked to that original 94% efficacy, 93% efficacy, which is durable for 5 months. And so demonstrating that immunobridging gives us confidence that we will restore immunogenicity to the level it was post-dose 2. In this study, aligned with FDA guidances around licensure of COVID-19 vaccines, we had 2 co-primary endpoints. One in terms of GMT ratios, or GMR, and then one in terms of seroresponse rates. You will see that I'm going to present two analyses for each. One, the first one, will be what we actually pre-specified in our protocol. The second is additional analysis that had been requested as we filed and had our EUA review. So first, the geometric mean ratio, that was our original pre-specified hypothesis. Aligned with the guidance, we had a statistical criterion where the lower limit of the GMR had to be above 0.67, as well as a point estimate that was above 1. What you can see for the group that received the 50 microgram dose, and in this case we pooled both the 50 microgram prime and 100 microgram prime group, the GMR is 1.7 with a lower limit of 1.5. So the criterion is met. Next slide. And the criterion is also met if we consider only the group that received the 100 microgram primary series. So in this case, the point estimate is 1.8, and the lower limit remains 1.5. Next slide. There was a second pre-specified hypothesis based on seroresponse rate. And a seroresponse in this case was predefined as a 3.3-fold rise over pre-booster titers. And in the case of the pivotal phase 3 study, it's compared to pre-dose 1 titers. Now, why 3.3-fold increase? Because the characteristics of our assay, when subjected to statistical analysis, suggested that the inherent variability of the assay supports discrimination at the 3.3-fold level. And once again, this is the pooled primary series group. In this case, the seroresponse rate is 94%, and the lower limit is above minus 10%. The statistical criterion was minus 10%, so the criterion was met. Slide. Based on a 4-fold rise, as we were asked to do by the agency, and limited only to the group that received the 100 microgram primary series, the seroresponse rate was 88%. The lower limit was minus 16, and the criterion is not met. So next slide. Let's evaluate that criterion a little bit further and understand why that criterion was not met. So what we had noted throughout was that the pre-booster titers, particularly with respect to the Wuhan strain, which is what this hypothesis is based on, remained actually quite high. I showed you that in our exploratory analysis. And you see here an evaluation of the pre-booster titers and post-booster titers in subjects who did meet a 4-fold rise definition on the left and who did not on the right. What you can see is that there is an approximately 4-fold difference between the subjects who did meet the 4-fold rise definition with a starting titer of 108 to subjects who did not meet the 4-fold rise with a starting titer of 492. Nonetheless, both groups achieved post-vaccination GMTs that are well above the level of 1,000. And if you refer to the correlate of protection analysis that was performed by the NIH, the threshold of 1,000 was associated with protection that was approximately 96%. So although a correlate of protection has not been established, there has been an association of increasing neutralizing antibody titers, particularly above 1,000, with protection against disease. Next slide. So now I'd like to show you the individual fold rises overall and then by age group, because we are discussing in particular the need for a booster in those over 65 years of age. So what you see overall first for the Wuhan strain is that there's an approximately 12-fold increase pre-booster to post-booster, which rises to about 18-fold in subjects who are over 65. Next slide. And if we look at the cross protection now to the Delta variant, what you see is overall a fold rise of approximately 16-fold that rises to 22-fold in those who are over 65 years of age. Next slide. So now let's summarize. Next slide. In terms of safety, the rates of adverse reactions after the 50 microgram booster dose are comparable to those observed after dose 2. Pain remains the most common solicited local AR, and headache, fatigue, and myalgia are the most common systemic ARs in both groups. The majority are mild to moderate in severity. And axillary swelling or tenderness was the only AR more frequently reported after the booster as compared to dose 2 in study 301. We observed no vaccine-related SAEs or deaths in study 201B. There's at the moment a mean of 3 months of follow-up after the booster dose administration. Next slide. And in terms of immunogenicity, our pre-specified co-primary hypotheses were met on the pooled data set, although the additional analysis on seroresponse was not met. The 50 microgram booster dose, following specifically the 100 microgram primary series, resulted in higher antibody titers to the original virus than post-dose 2, and this is statistically significant, with a GMR of 1.8 and lower limit on the 95% confidence interval of 1.5. There's a 13-fold increase from pre-booster titers to the original virus and a 17-fold rise from pre-booster titers for the Delta variant. And we saw consistently high antibody titers in both those 18 to 64 and those over 65. Next slide. So finally, I just want to also give a thank you to the many collaborators on this study, and as always, the individuals who continue to participate and continue to allow us to learn from their data. And with that, I'll conclude, and happy to take any questions if there's time.
Thank you, Dr. Miller. This presentation is now open for questions. And I see Dr. Paling's hand is raised. Dr. Paling?
All right. Good morning. Thank you, Dr. Miller, for a very clear and informative discussion of these studies and using the data and crossover so effectively. I wanted to ask, if I understood correctly, there were 2 vaccine-related medically attended adverse events. Would you be willing to share what those were and provide some more information on that? Thank you.
So 2 vaccine-related medically attended events or 2 serious adverse events?
My understanding is there were no serious adverse events. It was 2 medically attended adverse events. Is that correct?
So we go back to the slides that I presented, and I apologize, I'm not going to remember the number in the safety section, reviewing the table of the unsolicited AEs. I just want to be sure I understand the question. Okay, so you're talking about the second row on the table.
I was talking about the one, yes, this table, yes, the second row. Thank you.
So I don't have that particular event or those events at my fingertips. Would it be all right if we go and look into the database and come back to that question a bit later in the discussion?
Absolutely, thank you.
Next, I see Dr. Long's hand is raised.
Yes, a very simple question. Is it your intention to use the exact same packaging for primary series and booster and merely instruct the administrator to withdraw a different volume?
That is exactly correct. So the administration of the booster dose will be a 0.25 ml volume, And we are going to proactively conduct education to make sure that it's understood how this should be given. So there is going to be a Dear Healthcare Provider letter. The information is updated in our fact sheet. Our medical teams are going out to do webinars for increased training. And then we will also have a 24/7 hotline as well as information on our website about how to administer this.
Thank you.
Dr. Sanchez.
Thank you, and thank you for the presentation, certainly encouraging. I, also had a similar question as Dr. Paling. I would like to know also what the serious adverse events that we're seeing, even if they were not felt to be vaccine related. So
sure.
And
so yeah, sorry, please go ahead.
That's okay. And specifically, were there any thrombotic events seen at all? Thank you.
So there are in the two groups. I'll start with the 100 microgram primary series group. There was a tendon rupture, and then there was one spontaneous abortion. In the 50 microgram primary series group, there was an older gentleman who had a deep venous thrombosis and pulmonary embolism. And then there was an 89-year-old female who had bradycardia and a pacemaker placed, who post-operatively had a case of pericarditis.
And in the case of the deep venous thrombosis and the pulmonary emboli, was it?
Yep.
That was which one? The group, the 50 microgram?
The 50 microgram primary series group. So 50 microgram booster after 50 microgram primary series.
And that was assessed as serious but not vaccine related?
That's correct. So this was a 71-year-old male. He had a past medical history of hypertension, and he developed his deep venous thrombosis and pulmonary embolism 79 days after the booster dose. So I think the time period in particular in that case and the fact that he was an older gentleman with risk factors contributed to the investigator's assessment.
Thank you.
Thank you, Dr. Lair.
Thank you for your presentation. I'd like to follow up on the comments of just taking out half the dose or the 0.25 mL. There's a comment from a Rebecca Coyle of the American Immunization Registry Association, which has concerns about that process being confusing for the American registries and keeping track of vaccines. So I'd like to refer you to that comment and see if you can make it easier for the public health to order and manage their vaccines. So it's part of the comment section on the docket today. Thank you.
Okay, thank you. I apologize. I don't think I have had the full context of the comment yet. Is that something that we can address after we've heard the comment during the comment session today?
Dr. Miller, this is Amanda. I think that the context of the concern, and we can hear from Dr. Coyle as well, but is related to the NDC codes being the same vial being used for both a primary series dose and a booster dose, and using the same NDC code doesn't allow for and from the inventory and product management and tracking of individuals who received doses perspective.
So I understand that the concern is around the code. I'm afraid I just am not quite certain how to answer to that, other than to say that that's a comment I'll have to take back to the group. This is outside of my area of expertise in research and development.
Great, thank you. And I see a couple of liaisons have raised their hands. Before we move on, I just did want to kind of put a point on the end of that sentence, which is not only are the billing codes important for us from a tracking and administration standpoint, and also I just want to, I worry a little bit about administration errors if we're asking people to draw up different doses from the same vial. But we also want to make sure that we're able to track in terms of our vaccine safety surveillance systems, and it's really helpful to have a specific code for pediatrics for this reason. I recognize that this is a broader question, but I wanted to make sure we're clear on this publicly, because I do think it will help our post-market safety surveillance systems as well as our post-market effectiveness data systems be able to track on making sure that, number one, people got the right dose, but second, that we have a good understanding of safety that doesn't require assumptions. Go ahead.
Dr. Lee, I was just going to say that we can have someone from CDC respond to some of these issues during the discussion portion of the agenda.
Okay, that sounds perfect. Thank you, Dr. Cohn. The other, it's more a generic statement that I do think, I have so appreciated that all of the companies have really come forth in the initial trials, including diverse populations, and it's becoming clearer that it has been harder to maintain that level of attention to including and enrolling diverse populations. So this is not specific to Moderna, but just, a call for continuing to maintain emphasis on that, because I think it's really important to all of us to ensure that we don't go backwards in terms of how much progress we've made in inclusive enrollment in clinical trials. I'll pause there and turn it. Sorry, go ahead.
May I just comment to that? Because I just wanted to lend the support of myself, but also the entire team at Moderna. We agree. And I think I just want to underscore that this trial was conducted at a time before we put in place the Inclusion and Diversity Board and all of the things that we did in our phase 3 study. And it's a big part of the reason why we think it's important to continue to capture data, not only to have a larger safety database from the Cova study with the 50 microgram booster dose, but also to continue to ensure that those results are generalizable. The reason why I've focused so much on the immunobridging to the Cova study is because in the Cova study, we saw no differences in efficacy between various racial groups. So just to say that we continue to put those strategies in place for our additional clinical trials. And then maybe finally, just to answer to Dr. Paling's comment, the two vaccine-related medically attended events were cases of headache and rash. And what really led to their assessment as vaccine-related, of course, was the timing when those cases occurred. So they were comparable to the things that we are collecting as part of our routine solicited AR. And thank you.
Thank you, Dr. Miller. I really appreciate your comments. I'll ask Dr. Kimberlin to go ahead and ask his question.
Yes, thank you. On slides 11 and 12 of your presentation, where you discuss COVID cases by month in vaccinated subjects and incidence rates of COVID-19 in early and later vaccinated groups, can you confirm that what the definition of a COVID case is? Are these asymptomatic detections in addition to symptomatic? Are they severe only, and so forth?
So these are the cases that met the primary case definition in Cova. So the primary case definition that we reviewed in the past was I'm going to correct myself. So there were a couple of areas where there were asymptomatic swabs taken. The vast majority of these are going to be symptomatic cases because that's what really prompted the swabbing. But this is the conglomeration of asymptomatic and symptomatic cases.
Is there any way to delineate or say whether these were more mild, for those that were symptomatic, more mildly symptomatic, or did they require hospital attention or evaluation?
Yeah, so I think what you're speaking to is the number of severe cases that were reported. And the number of severe cases was much smaller than the number of mild and symptomatic cases. So I want to say there were 9 or 10 severe cases overall. That may not be precisely the right number, but it's in the right direction.
Thank you.
Thank you. And the last
19 cases. Forgive me, 19 cases.
I see 3 more hands raised. I'm actually going to call on them, but I'm going to ask that we move on after this. So we'll go to Dr. Sanchez next.
Yes, thank you. And along with that, were the severe cases, were they from early or later? And Can you break those down?
Yes. So the case split for severe cases, early versus late, is 13 versus 6. And then there were 3 hospitalizations. All of them occurred in the earlier group. And there were 2 deaths. Both of them occurred in the earlier group. And the 2 deaths were both gentlemen who were in their 70s. Both of them had a history of COPD and other compromising medical conditions, diabetes and sarcoids.
Thank you. Dr. Long?
Yes, again, rethinking the, in quotes, need for boosters on an age-related basis. I think that you lumped your 18 through 64 and then 65 and older. Do you have more definition within that age group? And if you took away earlier and later and you merely applied age at the time of immunization for any severe cases that occurred in vaccinated people, I wonder if you have more definition that would help us in that big group 18 through 64.
Yeah, thank you, Dr. Long. That question is very relevant. I think it's been a bit difficult for us to go further into that 18 to 64 in the phase 2 study because of how small it is overall. In the phase 3 study, I guess I don't have age group above 65. We did adjust our analysis for various stratification factors. So we did look at age as a confounding factor as well as comorbid medical conditions. And then also looked at whether or not subjects were healthcare workers or not, assuming that they had higher exposure rates. And we really saw the same difference, so about a 36% difference, regardless of how we adjusted for these potentially confounding factors. So I don't have more age stratification than that, but I think it does imply that this difference between early and late is there no matter how we cut this data.
Thank you.
And could I have a very brief follow-up question?
Very brief, Dr. Long.
Okay, sorry. If you compare the geometric mean antibody in individuals pre-dose 2 of their 2-dose series with pre-booster GMT, what would you learn? Are they similar or dissimilar? I'm thinking
let me make sure I heard the question correctly. Is it you're asking pre-dose 2 versus pre-booster or post-dose 2 versus pre-booster?
Yes, pre-dose 2. I'm thinking about the relative risk of myopericarditis in people who have big antibody titers potentially when they get their second dose. And so I'm wondering what is the relationship between the geometric mean titer pre-dose 2 and pre-booster?
So I'm not going to be able to provide a very precise answer to that because I don't have the pre-dose 2 titers in mind today. I guess what I can share with you, and we did discuss this a fair bit at length in December, after the first dose, about half of the subjects have neutralizing antibody titers, but there's a good percentage of subjects who really need the second primary series to achieve neutralizing antibody titers. And there's probably a good log difference of titers between pre-dose 2 and pre-booster. So they're not really the same population. But what I think is important is that the antibody titers have waned substantially. So they are about a log lower pre-booster than they were post-dose 2.
Thank you.
Thank you. And Dr. Hoag, last question.
Thank you so much, Dr. Michael Hoag with the American Pharmacists Association. Dr. Miller, thanks for your presentation. Pharmacists are concerned about the booster dose and the sterility of the product. We're looking now at potentially double the number of entries into a vial with a needle. Has Moderna done any studies looking at continued product stability or sterility? Have you looked at the integrity of the rubber stopper? Have you done the motion studies to ensure that we can safely administer the vaccine at booster doses with twice the number of entries into the vial? This is just a very concerning issue and perhaps might make the case that it would really be helpful if Moderna had a separate booster vial, separate product that's designed just for boosters with a smaller volume. But I'm wondering if you have any of those studies or if that's material you could make available to us.
Yeah, thanks for that also very relevant question. We have actually done multiple in-use studies, so that was really a part of the overall submission. What will be in the labeling information is that 20 entries into the vial are the maximum that can be used, and that is supported by data. There's also the stability data to support all of the storage and handling information that you'll find in that vial. And I just want to comment that in the context of the pandemic, this is the way that we are managing the 50 microgram booster dose now. And that's actually consistent with how other pandemics have been managed with different doses for potentially different populations, like the H1N1 pandemic. Moving forward, we are looking at packaging a product differently. And this also is relevant for the pediatric vaccination program that we currently have ongoing, where we certainly will be pressing forward with lower doses in the primary series. So this is a measure that we're putting in place now, given the current context of the Delta surge and the need to make these booster doses available. So completely hear your feedback.
Thank you very much. And we need to move on to the next presentation, which will be Dr. Penny Heaton and Dr. Makaya Dr. Duogi from Janssen talking about booster dose data. So we'll transition on.
Okay, great. Can you hear me okay?
Yes, we can.
Great. Good morning, everyone. My name is Penny Heaton, and I'm the Global Therapeutics Area Head for Vaccines at Janssen. I want to thank you for the opportunity to brief the committee today and thank the committee for their tireless work. We'll be talking about, of course, our Ad26 COVID vaccine. More than 14 million adults in the U.S. have received Janssen's vaccine. And while the single dose has provided durable efficacy against COVID-19, the data we're going to share today with you highlight the opportunity to further increase protection with a booster dose. Now, as we begin, I think it's worthwhile to note that the Ad26 vaccine and our development strategy is different. First, the initial phase 3 study evaluated the safety and efficacy of a single dose regimen, and that was for efficient pandemic response globally. Second, the data from this study showed that protection is durable. The efficacy of a single dose has persisted for at least 6 months. Third is the unique immunoprofile. Antibody titers peak later, they persist for at least 8 to 9 months, and cell-mediated immunity is especially strong with CD4 and CD8 positive T-cell responses that are likewise durable. So although the durability is very clear, what's also evident is that there is room to boost protection, particularly against symptomatic infection. We believe a homologous booster dose aligns with the U.S. priority to optimally protect individuals against any COVID infection. And data from our booster studies show how the Ad26 vaccine can support this goal. The data show that a booster dose is safe and increases protection, including against symptomatic COVID-19. More than 9,000 individuals have received a booster dose of the Ad26 vaccine in our blinded randomized clinical trials. Janssen's second large randomized phase 3 study evaluated 2 doses of Ad26. a single dose with a booster that was given 2 months later. Efficacy against symptomatic disease was 94% in the US and 74% globally, and there was complete protection against severe COVID. The study also found a similar reactogenicity profile after each dose. And antibody titers increased rapidly, consistent with an anamnestic response. In a separate study, a booster given at 6 months induced even higher titers with a 12-fold increase. Now, regarding the Delta variant, there were not enough cases caused by Delta in our randomized trials to evaluate efficacy against this variant. However, we do have 2 lines of evidence that give us confidence in its efficacy against this strain. First, a large real-world evidence study in the US that was conducted when Delta became dominant showed similar efficacy as in our randomized controlled trials. And further, the booster at 6 months showed an increased breadth of immune response with neutralizing antibody titers against variants of concern, including Delta. I will now briefly share data from the final analysis of our pivotal single-dose trial. In the US, the efficacy of the Ad26 vaccine was 70% against symptomatic disease. Plotted over time, the efficacy did not wane for at least 6 months. We saw a similar level of protection in a real-world evidence cohort study showing that Ad26 remained effective in the US even as the Delta variant surged and remained stable for at least 6 months. That's through the end of August, the data that we have now. And the primary endpoint of the single-dose study was also met. Globally, efficacy was 75% against severe COVID-19 after a single dose, and the efficacy likewise persisted. In addition, protection against severe disease caused by emerging variants remained strong. However, when we looked globally at vaccine efficacy against symptomatic disease, we see a trend that decreases over time. An interrogation of the data showed that the reduction in global vaccine efficacy for symptomatic COVID appears to be driven by the emergence of variants rather than declining immune responses. 3 variants with vaccine efficacy below 50%, Gamma, Lambda, and Mu, they became prevalent in regions or countries outside of the United States during the period of analysis. Now, the vaccine's durability is also reflected in the persistent humoral and cell-mediated immunity. Recall that while antibodies are needed to prevent SARS-CoV-2 infection and to confine the virus to the upper respiratory tract, CD8 positive T cells are important for preventing spread down the respiratory tree and severe disease. And it's the totality of the immune response that protects against COVID-19. That combination of persistent antibodies, as shown here on the left, and a strong and persistent CD8 positive T cell response, as shown here on the right. And the latter, of course, is the hallmark of the adenoviral vector-based vaccines. That's why we see the strong protection against severe COVID-19 hospitalizations and deaths, despite the lower antibody levels elicited by Ad26 as compared to the antibody titers reported for the mRNA vaccines. Now I will turn to study 3009 that evaluated the booster dose at 2 months after the single dose. And we refer to this second dose as a booster dose for 2 reasons. First, essentially all participants had detectable antibody after the single dose. And second, the rise in antibody after dose 2 had the profile of an anamnestic response. This second phase 3 study was a large global randomized placebo-controlled trial conducted in 9 different countries across 3 continents. Once our vaccine was authorized for emergency use, the study allowed unblinding and offered any participants on placebo to receive our vaccine. Of the more than 31,000 participants who received the single dose, 53% received the booster before the crossover was completed, And so they are part of the double-blind analyses being presented today. And 25% of the participants evaluated for efficacy were at least 60 years of age. Here we show the efficacy of the single dose and booster studies. In the US, vaccine efficacy against symptomatic COVID reached 94% after the booster dose. And globally, the vaccine efficacy against symptomatic infection improved to 75% post-booster. And there was complete protection against severe outcomes. However, due to the limited follow-up time after the booster for the unblinding, the number of cases that occur during the observation period in the double-blind part of the study are limited. We also have additional immunogenicity data from other studies that evaluated boosters at different time points. Booster doses have been given at 2 and 3 months after the single dose in younger and older adults, and 6 months after initial vaccination in younger adults. Responses were evaluated with ELISA looking at binding antibody and also wild type and pseudovirus neutralization assays. And the neutralizing responses correlated strongly with ELISA. As you see, a booster administered at each of these time intervals resulted in increased antibody levels for those 18 to 55 years of age. And we saw similar increases in those 65 years of age and older. Importantly, when the booster was given at 6 months after the primary dose, it resulted in a 12-fold increase. Overall, these studies show that a booster dose of Ad26 enhances immune responses, and the benefit may be greater when given at 6 months or later. This finding and the durable efficacy profile are reassuring for those in the U.S. who received the Janssen vaccine more than 2 months ago. Thank you. I'll now turn the presentation over to Dr. Duogi.
Dr. Heaton, good morning. My name is Makaya Duogi, and I'm Head of Clinical Development at Medical Affairs for Vaccines at Janssen. Today, I'll present our safety experience with the Ad26 booster dose. Here you can see the cumulative exposure to a booster dose of Ad26, and that includes 9,220 participants across 5 clinical studies we've performed. The preponderance of data we have on the booster dose comes from study 3009, our phase 3 pivotal 2-dose study where the second dose was administered 2 months after the primary vaccination. So now I'll review the reactogenicity for the booster dose administered at a 2-month interval in study 3009. And since local reactogenicity was similar between the primary and booster dose, I'm only going to review the systemic reactogenicity here. So on the next slide, you can see the systemic reactogenicity for individuals 18 to 59 years of age, which is displayed on the left, and then the data for those 60 years and older is on the right. And within each column, the left bar is showing the reactogenicity profile for the primary dose, and the right bar shows the booster dose. And then the orange number above each bar is the percentage of grade 3 events. The data show that solicited systemic adverse events were less common and generally of lower severity with the booster dose compared to the primary dose in both younger and older age cohorts. You'll note that the frequency of fever following the booster dose is approximately half of what it was after the primary regimen in the younger cohort. The frequency of events was lower in the cohort of older adults, and grade 3 events were low overall. And there were no grade 3 fevers in the older adults after either the primary or booster dose. So next, I'll cover the 6-month reactogenicity profile from study 1001, which was our first in-human study, and preliminary blinded data from study 2008, which is ongoing. In study 1001, a subset of participants was boosted at 6 months following the primary dose. And the frequency of solicited systemic adverse events was lower with the 6-month booster than the primary dose. And although, as you can see, the numbers are limited, it appears that the systemic events were also milder in severity. And study 2008 is an ongoing randomized double-blind trial of participants originally enrolled in our single-dose pivotal trial, study 3001. And this study is evaluating 3 different dose levels of an Ad26 booster at least 6 months after the primary vaccination. We have 127 participants that are estimated to have received the dose level being considered as a booster today, and the blinded safety data are available on a total of 83 participants to date. While the dose level data remain blinded, it's reassuring to note that no grade 3 systemic reactogenicity events have been reported. So overall, when a booster is given at 2 or 6 months, it did not result in any increase in solicited reactogenicity compared to the primary dose, and in some cases showed a trend towards decreased reactogenicity. Next, I'll present unsolicited adverse events from the safety subset of Study 3009. And before going into the details, I know this is a topic of discussion. I'm happy to answer more questions in the Q&A, but we had very good diversity in our demographically in our phase 3 study, and this was very closely matched in our safety subset as well. So overall, the frequency of unsolicited AEs was similar between groups and similar to the single-dose pivotal study. The rate of unsolicited adverse events was 15% in the Ad26 group compared to 10.9% in the placebo group after the first dose. This imbalance was driven by vaccine-associated events such as fatigue, injection site reactions, and headaches that were captured outside of the safety subset. The rate of unsolicited AEs was also similar between the groups after the second dose. Rates were balanced as well in the full analysis set for the medically attended adverse events, any SAE not due to COVID, and deaths. The number of deaths was numerically higher in the placebo group, so 13 versus 4. Among those who died, none in the Ad26 group were considered related to the vaccine, and none were due to COVID. 6 of the 13 deaths in the placebo group were attributable to COVID-19. Now I'll review the 3009 data on adverse events and adverse events of special interest, or AESIs. So following the identification of a safety signal for very rare events of thrombosis with thrombocytopenia syndrome, or TTS, in the post-authorization data, TTS was considered an AESI in our clinical study. In study 3001, 1 case of thrombosis with thrombocytopenia occurred in each group. 1 participant in the Ad26 group experienced thrombocytopenia 86 days following vaccination, followed by cellulitis and DVT approximately 100 days post-vaccination, and was also diagnosed with COVID-19 during this event. Anti-PF4 results were not reported. 1 participant in the placebo group had a DVT on day 27 during the double-blind phase and subsequently developed a pulmonary embolism 2 days later in combination with thrombocytopenia. Neither case met CDC criteria for definitive TTS. Because there were no confirmed TTS cases in this study, and because these events are extremely rare, we looked into post-marketing data collected by the government in the UK for the AstraZeneca 2-dose vaccine, since it is another viral vectored COVID-19 vaccine. With 24.9 million first doses and 24 million second doses administered, the estimated rate of blood clots with concurrent low platelets was 15.1 cases per million following the first dose and 1.9 cases per million with the second dose. The overall case fatality was 17%. 66 deaths occurred after the first dose and 6 occurred after the second. The government's interpretation is that there's no indication of an increased risk of these events after the second dose in any age group. So here there are some adverse events of interest for study 3009. And the first 3 were selected due to imbalances that we observed in our single-dose pivotal study, specifically embolic and thrombotic events, convulsions or seizures, and tinnitus. In study 3009, we saw no imbalances for thrombotic events or seizures. However, although the numbers are small, we did see an imbalance of tinnitus following the first dose, and then no difference after the booster. Guillain-Barré syndrome and facial paralysis are events of interest for all COVID-19 vaccines, and we saw no imbalance in our 3009 study. A numerical imbalance between the Ad26 and placebo group was observed for arthritis, which was not observed in our single-dose pivotal study of 40,000 participants. In study 3009, the observed imbalance was due to events which occurred 28 days after the primary dose. There were no clear patterns of differences on the level of preferred terms between Ad26 and placebo, and a large proportion of these cases were apparent exacerbations of existing conditions. The majority of these events were non-serious, and there was no imbalance in the 28-day period in terms of events following the booster dose. So in the context of greater vaccine efficacy with the booster dose, the study showed that the reactogenicity and safety profile of a booster at 2 or 6 months was similar to the single-dose primary regimen. The incidence and severity of local adverse events was also similar, regardless of the timing of the booster. And systemic AEs appeared to be lower and of milder severity at 6 months relative to 2 months. Our large randomized placebo-controlled study 3009 did not identify any new safety signals for AEs, SAEs, or AESIs with the booster dose. Global post-marketing surveillance of the 2-dose AstraZeneca COVID-19 vaccine suggests that rare TTS events are much less frequent after a second dose than after the first, and no TTS cases following the booster dose have been observed for Ad26. And finally, we will revise our ongoing and planned post-authorization studies to incorporate follow-up of booster doses in addition to the primary doses. Thank you. I'll turn it back to Dr. Heaton.
Thank you. And I'll offer just a brief conclusion before we take your questions. Janssen's randomized placebo-controlled trial provides strong evidence of the safety and efficacy of a homologous boost of Ad26 vaccine. The Ad26 vaccine immunoprofile is unique. Immune memory is a hallmark of the platform. Cell-mediated immunity, including CD8 positive and CD4 positive T cell responses with maturation of potent neutralizing antibody, are all important contributors to protection. And that protection is higher with the booster dose. As shown in study 3009, the point estimate of efficacy was 94% against all symptomatic disease in the US, matching the peak efficacy that reported for the mRNA COVID vaccine.
Dr. Heaton, I think we've lost your audio. I don't know if Dr. Duogi wants to stand in or if there's also...
Yeah, maybe. I'm sorry, I was going right away. I'm right here. Can you hear me now?
Oh, yes,
Sorry.
we can. Thank you.
Yeah, I don't know exactly what happened, but here I am. Did you hear any of the slides?
We got down to the vaccine efficacy. Thank you.
You got an efficacy. Okay, that's interesting. Okay. So you heard the efficacy against symptomatic infection boosted to 94% in the US with complete protection against severe disease globally. Further, the magnitude of the safety information from a randomized controlled trial is also unique to the Janssen program. More than 9,000 participants have received a homologous Ad26 boost that provides us with a large safety database showing that the booster dose is safe and well tolerated. We believe this robust data package supports the administration of a homologous booster dose for Janssen vaccinated individuals. The data show how the Janssen COVID-19 vaccine can help further protect individuals from COVID-19. As such, we strongly support the VRBPAC recommendation, which provides flexibility for...
We lost you once more, Dr. Heaton.
I do not know why it's automatically putting me on mute, but anyway. And so in summary, we really strongly support the VRBPAC recommendation, which provides flexibility for administering the booster dose of Ad26. Any of the more than 14 million who received their COVID vaccination with Ad26 have the information needed to determine the timing of the booster dose at least 2 months following the first dose, or at 6 months or later to maximize durable protection. And any person who may get it in the future will likewise have the right data for scheduling their booster.
Thank you very much, Dr. Heaton. If you've concluded your remarks, we would love to open this presentation for questions from the members. Dr. Talbot.
Yes, I just had one comment. The last safety slide, if that could go up, where you talk about the TTS following second dose. I don't know if you know, since that was the AstraZeneca vaccine that was used in the UK, but if I recall, they had stopped using that vaccine in young, healthy women prior to most of them getting a second dose. So I'm not so sure that data is helpful. Is that correct?
Hi, this is Makaya Dawugi. I think so for the UK, that may indeed well be the case. And I think different countries within Europe, obviously also, because there's a larger data set in terms of what's distributed, have been administering it to different age groups. But I do think that the difference still is fairly substantial in terms of, if you look at the denominator, the difference is still striking. And of course, it's not replacing any data that we would generate with our vaccine, but we do think it's important to monitor this.
Yeah, and I think I'm just pointing out that the main risk group for that syndrome was pulled out of the group getting the vaccine, so it's difficult to determine the impact of a second dose because of the change in the denominator. Thank you.
Thank you. Dr. Sanchez.
Thank you, and I just one clarification of question. The booster dose is the same dosage as the initial dose, right?
That's correct. Yes.
Okay. I just wanted to clarify that. And then the other thing was related to the embolic and thrombotic events. So there were 3. I know that there were 3 in the in the J&J vaccine versus 3 in the placebo, but those did not meet the definition of the thrombotic events. This was from slide
28.
I don't see this one here, exactly. So those cases of embolic and thrombotic events, they did not meet the definition of PTS, or what?
No, those were not accompanied by low platelets.
Okay. And do you know what kind of events, thrombotic and embolic events, were they?
DVT and PE. I'm looking to see if I have the exact numbers in front of me. But yeah, they were DVT and PE mainly.
Thank you.
Thank you. Dr. Daly.
Yes, thanks so much. I have 2 questions. The first is on slide 12, and I'll take these one at a time. So if you could discuss more the difference in symptomatic COVID-19, efficacy against symptomatic COVID-19 in the U.S. compared to globally, because if I'm interpreting this correctly, it's 94% in the U.S. and 75% globally, and sort of what explains that difference?
Yeah, it is the variants. If you look at efficacy against the Alpha variant, which was the predominant strain in the U.S. at the time, the efficacy was 94%. If you look at the efficacy against Mu variant, it was 63%. So it's the variant efficacy that is responsible for that difference. Does that answer your question?
Well, it does. I mean, I think then we need to infer what efficacy in the U.S. would be in the context of Delta. So, okay, thank you.
That's exactly right. And that's why, we didn't have any Delta cases, the Delta strain that was circulating in the U.S. at the time of the study. And that's why we looked to the real world evidence that so far we're following it month over month. And so far the efficacy, and that's with the single dose now, of course, has been around 70% to 80% efficacious, depending on the severity of the disease. We are also, of course, continuing to look immunologically at the neutralizing antibody titers, and those data also show good neutralization of the Delta strain that is currently circulating. So it's something we're continuing to monitor as well.
Okay, yeah, thanks so much. And then my next question is on slide 16, please. So am I correct in understanding that there were 17 individuals, 18 to 55 years of age, who received a booster dose at 6 months? And so then that's the sort of totality of the data that we have in that group. And I guess the follow-up question to that is, are there plans to study this in a larger sample size? Because I think many of the individuals who received a Janssen primary dose would be closer to 6 months following their first dose rather than 2 to 3 months following their first dose. Thank you.
Yes, so there are several individuals. In fact, the sample size of that study, well, let me just address the 17. So the 17 are the ones that we have unblinded, and we have, and that's in study 001. It was an early study where we were able to look at the safety and immunogenicity of the booster dose when given at 6 months. And so, yes, that was an early study, initial data. We have an ongoing study that is still blinded, and we are anticipating data on that. And Micaiah, correct me if I'm wrong, I think it's about 270 subjects. We're anticipating data on that imminently. So we'll have additional data at the 6-month mark in just the next few weeks.
Thank you.
And maybe I can, well, I think it's 330 for the non-inferiority assessment. So, and we will, that's for homologous boosting, and we'll also be looking at heterologous boosting formally as well. And just to mention that for both of our phase 3s, we've amended the protocols to introduce boosters, which will be 6 months or later for the most part. So we'll have actually data going further out from 6 months, even in some participants. So that will generate a lot additional safety data, as well as we'll be able to monitor for immunogenicity and efficacy.
Thank you. Dr. Paling.
Yes, thank you, Dr. Heaton and Dr. Dewey for these great presentations. The question I wanted to ask was, I understood there was a commitment to diversity in the population. So in those that received the booster dose, in the 18 to 55, can you clarify how many were women, particularly in the 18 to like 30-year age group? Thank you.
Do you mean from our phase 3 study?
Yes.
Okay, so gender, I will have to see if we can pull that up and answer that for you. So maybe let me look and see if I can come back during the Q&A.
That sounds good. I will move on to Dr. Grog.
Yeah, I thank you both again for your presentations. Do you have any data on immunocompromised patients as far as the booster effect goes?
Yeah, we do have efficacy on individuals with comorbidities. And when you look at that data, it shows the efficacy point estimates, and this is against all symptomatic disease, was 77.9%. Now, within that, as we start to look at those with severe immunocompromised, the numbers get smaller and smaller, and it's hard to draw any conclusions. But is that helpful? Does that answer your question, or do you want us to get more information for you?
I hope in the future you'll have more information on the immunocompromised.
On the immunocompromised, yeah, we do have that information that's forthcoming, and we can get that for you. Yeah.
Thank you so much.
Dr. Duoge, I'm going to go to Dr. Sanchez first for the next question, and we'll come back to you to answer Dr. Paling's question. Dr. Sanchez?
Thank you. And also along with that, were any pregnant women included in the study? And what is any adverse events or any data on pregnant women and the vaccine? Thank you.
Micaiah?
So multitasking, but yeah, so we didn't include pregnant women in our efficacy studies, but we do have a separate study that will enroll approximately 400 pregnant women in the second and third trimester, and that is ongoing. It started in September. So we are generating data in a clinical study, and I'm maybe going to ask Dr. Marie if he could to cover the exposure data that we have in terms of pregnancies in our clinical trial.
Thank you, Dr. Duoge. Thank you, Dr. Sanchez, for your question. In fact, we do have limited information on pregnancy outcomes following vaccination. We have 54 reports from clinical trial data and 320 pregnancy reports from post-authorization, spontaneous and solicited data sources, including 58 cases reporting breastfeeding. No safety signals have been identified. A pregnancy registry is ongoing, and it would be modified to encompass the evaluation of a booster dose if authorized, or as authorized.
Dr. Duogi, did you have the time to respond to the other question?
I'm still trying to pull it up, so maybe.
Okay. Let me ask one more question.
I think we have. Yeah.
And hopefully it won't be directed. Yeah. Hopefully it won't be directed at you. But I wanted to ask if you are also considering. Well, first, let me just start out by saying I really appreciate the work that you've done to present on the broader set of immune responses to a single-dose vaccine. I actually think it's incredibly helpful, and it's been nice to see that data, and I do find that it is reassuring. And also just speaks to the fact that we can't rely on just one arm of the immune system for the immune response, and we all know that, but it's been nice to have you present that data. The question I have is whether or not you are doing any prospective looks in terms of anti-PF4 antibody measurement post-dose 1 and post-booster. And I ask because, a lot of what our efforts are centered around are trying to mitigate risk as much as possible, both from disease as well as vaccination. And that might actually give us some information about whether or not a different boost would be appropriate, for example, for young women.
And that's a question for Micaiah. Again, she's the one who's leading that effort. She's multitasking.
Yes. I'm sorry. Could you just repeat the question?
It was about checking anti-PF4 antibody measurement. But Dr. Duogi, if you want, we can actually come back to you after the next presentation, and you can answer both those questions.
Well, I can answer the first one now. So
okay.
Just to let you know that, yeah, we are looking at anti-PF4. So we started looking at participants who've had thromboembolic events in both the active and placebo groups, and also people who have not, and looking at data. So that's within the COVID program. We are also evaluating people who are in Ad26-based vaccine studies that are non-COVID vaccines for comparison. And just preliminarily, we're seeing that we do see PF4 positivity in both placebo and active groups, although we have fairly small numbers. So we, it's not a definitive look now, but we do see that for people who have thromboembolic events, that there is positivity in both people who have received the vaccine and not. But we will have more to report probably in the coming months as we continue this analysis.
Thank you. That would be really helpful. And just to broaden the question, to other manufacturers, not right now, but just as a discussion point is similarly, I think, looking at cardiac enzymes, post-booster dose or post-dose 2, even in asymptomatic individuals who are enrolled in clinical trials, I think could be incredibly helpful for us, again, to understand if there are any patterns and whether or not we can further mitigate risk with our recommendations. Why don't we do this? Why don't we move on to the next presentation by Dr. Robert Atmar on the NIH study on mix and matched boosters. And Dr. Duogi, we will come back to you after Dr. Atmar is done.
Thank you, Dr. Lee. And thank you for the opportunity to present our data to you. And I'm happy to represent our study team, including my study co-chair, Dr. Kirsten Light. Next slide, please. So as disclosure, I've received federal funding for this and other COVID-19 related vaccine studies. Next slide. The mix and match study is an open label, non-randomized, adaptive design, multi-center study to evaluate the safety, reactogenicity, and immunogenicity of COVID-19 booster vaccines in persons who had completed an EUA vaccine regimen at least 12 weeks earlier. Participants were 18 years of age and older, healthy or with stable underlying disease, not immunocompromised, not pregnant, and with no history of SARS-CoV-2 infection by history, and consented to participate in the study. Approximately 50 persons per EUA vaccine group, with approximately even numbers of persons 18 to 55 years of age and 56 years of age and older, were enrolled sequentially in 3 stages. The first stage began in early June, and participants received a 100 microgram dose of the Moderna vaccine. Participants received the Janssen vaccine in the second stage, and the Pfizer vaccine was administered in the third stage. The 9 groups are shown on this slide. A safety call was made at study day 8, and the participants returned or will return on study days 15 and 29, as well as at 3, 6, and 12 months for blood draws and safety evaluations. Next slide. Next slide. The characteristics of the study participants are shown on this slide. Again, approximately 50 persons per group were enrolled, and the mean age per group ranged from 48 to 57 years. The distribution of the study population by race and ethnicity did not fully represent that of the U.S. population. And the average time from completion of the EUA regimen to boost progressively increased across the stages due to the sequential enrollment set forth in the study design. It also tended to be shorter for those who received the Janssen EUA vaccine regimen versus those who received an mRNA vaccine under EUA. 2 persons, 1 each in groups 4 and 6, had evidence of prior SARS-CoV-2 infection based upon a high antibody level to the N protein at baseline. And 1 other participant in group 5 developed COVID-19 on study day 27. None of these individuals were excluded from the analyses I'll present. Next slide. Next slide. This slide shows some of the antibody assays being evaluated in the study. Pseudovirus neutralization assays are being performed in the laboratory of Dr. David Montefiore at Duke University, and IgG binding antibody assays are being performed in Dr. Adrian McDermott's laboratory at the Vaccine Research Center at NIH. The virus strains shown in green are the data for which I'll be showing you today. Next slide. This slide shows the immunogenicity results for days 1, 15, and where available, day 29. The top 3 panels show IgG binding antibody levels to the WAL1 strain, represented as binding antibody units per mil. And the bottom 3 panels show neutralizing antibody levels to the D614G strain, expressed in international units per mil. Both of these are values that are adjusted based upon the use of WHO reference standards. The data are shown both as individual values and as box plots, with the middle bar representing the median, the bottom and top of the box representing 25th and 75th percentiles, respectively. The whiskers represent up to 1.5 times the interquartile range. In panels B and E, the red dots represent the 2 persons with evidence of prior SARS-CoV-2 infection. The x-axis shows steady day, and the y-axis shows antibody level. And the Janssen, Moderna, and Pfizer EUA recipients for each stage are shown left to right in each panel. You can note that at baseline, the lowest antibody titers tended to be in those who received the Janssen vaccine initially, followed by those who received the Pfizer and then Moderna vaccine. All groups show a boost by study day 15. For those boosted with Moderna, antibody levels were level or decreasing slightly by day 29, while those boosted with the Janssen vaccine had slightly higher antibody levels on average by day 29. We don't yet have data for day 29 for the Pfizer vaccine recipients. The lowest post-boost titers were in those who received the Janssen vaccine initially and then were boosted with the Janssen vaccine. Not shown here is that the magnitude of responses in the younger and older age strata were similar, so we only present the pooled data for each group. Next slide. This slide shows IgG binding antibody responses as measured in a non-validated 10-plex CLIA to the WA1 or WAL1 strain in yellow, the alpha variant in blue, and the delta variant in pink. As in the prior slide, all groups had increases in antibody levels after boost, with the highest levels achieved to the WAL1 strain, followed by antibody levels to those for the alpha and then delta variants being progressively somewhat lower. The patterns of responses in the different vaccine groups were similar to those seen in the prior slide, And notably, the range of antibody levels decreases after boosting. Next slide. Next slide. We had two unrelated severe adverse events occur. The first was acute renal failure due to rhabdomyolysis from a fall that occurred 30 days after Moderna boost. The second was an episode of acute cholecystitis that occurred 24 days after a Janssen boost. We had no pre-specified study halting rules met, no new onset chronic medical conditions occurred, and one related adverse event of special interest based on it being a medically attended visit for a person who developed severe vomiting determined to be related to their Janssen boost. Next slide. The frequency of unsolicited AEs deemed related to the booster vaccine was similar across the booster groups, and most were grade 1 or 2 in severity. There were 4 unsolicited AEs deemed to be related and severe. In addition to the vomiting for the Janssen boosted individual mentioned previously, severe vomiting occurred in a person boosted with the Moderna vaccine, and severe fatigue and severe insomnia were additional AEs that were reported individual reported in individual Janssen vaccine boost recipients. Next slide. Solicited AEs are shown in this slide and included both injection site and systemic reactogenicity. These are basically as expected based on what has been reported in prior clinical trials. The most common events were injection site tenderness, followed by malaise, myalgias, and headaches. Most reactions were mild or moderate in severity. Next slide. So here are some of the limitations of our study. It was non-randomized, open label, and subjects were enrolled sequentially for the different stages. The study was not designed to compare between boosts. For example, we didn't control for intervals between primary vaccines and boosts. Correlates of protection are not completely elucidated, and they are even less well understood for severe disease and death. Today, I'm only presenting antibody data. We are measuring cellular immune responses, but those have not yet become available. These data also only represent early time points from the trial. So the vaccines may differ, as we've heard earlier, in time to reaching peak responses and may have different durability of those responses. Next slide. In conclusion, use of the Moderna, Janssen, and Pfizer vaccines as boosters led to anamnestic serologic responses in all 3 EUA dose vaccine groups. For a given primary EUA COVID-19 vaccine, heterologous boosts elicited similar or higher serologic responses as compared to their respective homologous booster responses. mRNA vaccines resulted in higher antibody levels in the first 28 days after the boost, and we did not identify any safety concerns. More information related to the study results are available in the preprint at the link shown at the bottom of the slide. Next slide. So I'd like to acknowledge the contributions of our study team, including the 10 clinical sites shown in black, our research labs shown in blue, and our regulatory data and statistical centers shown in green. We also acknowledge each of the pharmaceutical companies for allowing us to cross-reference their INDs. The vaccines used in the study were acquired through the U.S. government. Next slide. I'm happy to take questions.
Thank you, Dr. Atmar. This presentation is now open for questions. Dr. Brooks?
Yes, thank you for that excellent presentation. You stated that the smallest boost came from Janssen after Janssen primary series, is that correct?
That's correct.
So do you think that's related to the interval between the primary and the boost? As their data showed that their response was much better after 6 months as opposed to 2 or 3 months.
I think that so what I reported on really was the magnitude or the level achieved post-boost. I think that they started lower and the antibody responses seen after their vaccine is known not to achieve the same levels as after an mRNA vaccine. And so that they did not achieve as high a level after a boost with their vaccine is not particularly surprising to me, and it's consistent with what's been reported after the primary vaccine regimens.
Okay, thank you. And they also said it takes longer for the vaccine antibody levels to peak. So that might be part of it too.
And I did point out that the day 29 levels were somewhat higher, whereas it looked like, at least with the Moderna vaccine, that we saw a peak at day 15, the day 15 time point compared to day 29.
Thank you.
Thank you. Dr. Sanchez?
Thank you, Dr. Advar. This was really an incredibly important study because it really is exactly what we need in the real world. But I have a couple of clarifications. The primary series, and just clarifying, so the Moderna and the Pfizer, had they only received one dose or had they received two doses and then you boosted? And just to clarify that.
Sure. So for those who had received the Pfizer and Moderna vaccine, they had received two doses. For the Pfizer, the EUA was for 3 weeks between the first and second dose. And for Moderna, it was 4 weeks. And most of our subjects, were within this range. We allowed as many as 6 weeks between the first and second dose to be considered related to the EUA regimen. And that was based on ACIP recommendations about maximum interval at the time. For the Janssen, they had only received the single dose.
So we really don't know one dose of Moderna, let's say, followed by one other different, like the Pfizer. Those were not the enrollment criteria.
Right. We were interested in examining a booster response in people who had received an EUA regimen as recommended by the ACIP.
And the booster for the Moderna is actually the original dosage rather than the 50 that's being recommended now.
That's correct. At the time we started the study and we're planning the study in the spring, Moderna had not yet made a decision as to what their booster regimen would be. They were evaluating, as we heard earlier, the 50 and the 100 microgram dose. And we started with a 100 microgram dose. We actually, as I mentioned before, this is an adaptive design study. And we most recently have enrolled subjects with a 50 microgram boost, but we've not yet reached day 29 for the last individual enrolled in that stage.
No, thank you. Thanks for the clarification, and really, it's a really important study. Thanks.
Thank you.
Thank you. Dr. Paling?
Thank you, Dr. Atmer. I very much appreciated this great study and the information that you're sharing. We also appreciate that you're going to be doing cellular immune responses and look forward to seeing those in the future. My question is, if I'm understanding it correctly, there's 50 per group with 9 groups, so a total of about 450 persons were enrolled in these studies, and it included healthy and stable chronic conditions. Among those people with stable chronic conditions, was there any cases of exacerbations that you observed? Thank you.
No, I don't think there were any cases of exacerbations. There were isolated cases where there might be a high blood pressure, but, at a study visit, but nothing that was persistent or was considered an exacerbation of their underlying disease.
Thank you. Dr. Daly?
Yeah, just a quick point of clarification. Could we go back to the slide that showed the length of time between completion of the primary series and the booster dose received? I just want to compare that to what's going to happen in reality. It might be 5 or 6, something like that. There. Okay, so Dr. Atmar, could you just sort of orient me to this? The 15.4, 18.4, and 21.5, that's the length of time in weeks between completion of the primary series and the time that those recipients received their booster?
That's correct for the entire stage. And then if you look underneath those numbers in the next line, for example, in those boosted with Moderna, the interval was 13.7 weeks on average for Janssen recipients versus 16.4 for Moderna primary series versus 16.8 for the Pfizer primary series. And so by the time we get out to those boosted with the Pfizer vaccine, we're getting close to 6 months.
Great, thanks. It's very helpful just to review that after we've seen the results. Thanks so much. Sure.
Thank you. And Dr. Schmader, thank you for waiting so patiently. Please go ahead.
No problem. What a terrific study, Dr. Atmar, and thanks for all your work on it. As you know, the risk of serious illness in staff is highest in people 75 or over 80. How many subjects were 75 and older in this study? I know it's hard to meet all the demand for all these groups, but I just wonder.
There were a handful. Most of, I would say, no more than 2 or 3 of the average 25 individuals in the 56 and older for any single group. Let's see. You can see that in almost all of the groups, there's at least the oldest individual on this slide in the range is older than 75 or older. It looks like only in the Janssen boosted with Pfizer group, we didn't have anybody in that age range. But when we did have, people in that age range, it only was 1 to 3 overall.
Thank you.
Thank you, and thank you, Dr. Atmar. I know we are at time, but I actually would like for Dr. Duogi to be able to respond to Dr. Paling's question from earlier. Dr. Duogi, are you on still?
Yeah, she is working with the statistician to get that. One other question that I can offer an answer to, I believe it was Dr. Grogg's question on immunocompromised data. We've got that now. Can I share that very quickly?
Sure.
Okay, so there weren't very many immunocompromised patients in our randomized controlled studies, but in our real-world evidence studies, we had 29,000 individuals who met the definition of immunocompromised, and that includes active cancer, a history of organ or stem cell transplant, primary immunodeficiencies or HIV in that first year, or on immunosuppressive therapies. And the efficacy of the vaccine, the effectiveness, I should say, the effectiveness of the vaccine was 67% against hospitalizations in those individuals. So we do have that data, and we're continuing to follow this over time and follow, of course, safety in our pharmacovigilance as well as the effectiveness data.
Thank you so much.
Mm-hmm. Yeah, and then I think, Micaiah, are we going to be able to get that breakdown, or is it just that it's an analysis we usually don't do in quite that way, that stratification? But Micaiah, are we going to be able to get that now, or are we going to have to provide it later?
I'm wondering if we can just signal Dr. Lee if we have that information maybe after the break. And I do apologize, but we are trying to share as much data as we have. We don't have all of our outputs, and that is a breakdown that I think they're just checking to see if they can produce that. So it might require a little more time, but it's an important question. So I don't want to think that we're not thinking about it, but we still have, we're still analyzing these data. So would that be a possibility, Dr. Lee?
Yes, I think what I would suggest, and first of all, let's just say thank you for trying to answer this question on the spot. To give you the time that you need, I'm going to suggest that you connect with our work group leads, and they can make sure that the ACIP members have the information from the question that was asked. But we really appreciate you working so hard to get that to us. I am aware of one last comment from Dr. Alt, and then we will plan to take a 10-minute break and then move to public comment. So Dr. Alt, the floor is yours.
I just wanted to comment. I think the last time we talked about the Johnson & Johnson vaccine, or one of the first times we talked about it, we had mentioned that the Ebola vaccine that they had the same vector, and they had lots of experience with pregnancy. So I was trying to answer Dr. Sanchez's question from previously. Of course, we have VSafe and VSD data that we can look at as well. So that was my brief comment.
Thank you, Dr. Alt. And with that, we will recess for 10 minutes and plan to meet at 16 minutes after the hour for public comment. Thank you, everybody.